Hi, I'm Dr. Jason Siegel, and welcome to Neuro Now. So, November is Epilepsy Awareness Month. So, today I'm interviewing one of the most knowledgeable and experienced epilepsy specialists in the United States and probably the world. Dr. William Tatum is a neurologist at the Mayo Clinic in Florida, where he's a senior consultant and a professor of neurology. He's also the director of their comprehensive epilepsy program and the director of the epilepsy monitoring unit. He is a fellow in the AAN, ACNS, and AES. He did his residency at the Loyola University in Chicago and his fellowship at the University of Pennsylvania before joining Mayo Clinic in 2009. He has had numerous national leadership roles, including being the past president of the ABCN, the ACNS, and is the immediate past chair of the AAN Clinical Neurophysiology section. He has served on the board of directors for the Neurodiagnostic Society and the EFA Professional Advisory Board. He has authored or co-authored more than 240 peer-reviewed manuscripts, 47 book chapters, and has edited or co-edited 8 books or editions in the field of epilepsy and clinical neurophysiology. He is on the editorial board of numerous books and journals in the fields of neurophysiology and epilepsy. He is asked to present at national and international conventions. He continues as a principal investigator for several pharmacological and device trials with research interests in drug-resistant epilepsy, seizure semiology, and EEG and clinical neurophysiology. I've known Dr. Tatum for several years. I consider him a mentor. I consider him a friend. He is somebody who has taught me that if you truly want to be great at something, you must be passionate about it. And this man is definitely passionate about epilepsy. So before we go on, please remember to like, subscribe, and share this video. Write a comment below if you enjoyed it. And without further ado, here's Dr. Tatum.
All right, Dr. Tatum, it's so great to have you here. I'm really excited to talk to you again. This is Epilepsy Awareness Month, so let's make the people aware of epilepsy. Start us off. What is epilepsy?
So thanks for asking, Jason, and thanks for having me on your program. Epilepsy is one of the top concerns for people, not only in the United States, but in the entire world. Epilepsy itself represents unprovoked, recurrent seizures. Simple as that.
What's a seizure?
So when we talk about seizures, there are many different types, and that's where it can get kind of confusing for your audience. But when we talk about seizures, we talk about a sudden, excessive explosion from electrical activity in the brain cells that we call neurons within the brain. And depending on where it is, it may manifest and or show itself in different fashions. Probably the most feared that people think of when they think of a seizure are grand mal seizures, or what we call generalized tonic-clonic seizure. These are convulsions where people are stiff and shaking. But
What other kind of things can people look for, should parents look for, that might give them a clue that, oh, there might be, a seizure going on or something like that?
so that's a really great question. And the reason is because oftentimes, while it may be the big one or the convulsion or the grand mal seizure is the one that leads to the diagnosis, oftentimes it's not the first. And as a neurologist, that there are other smaller types of seizures, such as brief twitches or staring episodes, that often go unnoticed for many years before the first generalized tonic-clonic seizure occurs. So in fact, the vast majority of people don't manifest ongoing grand mal seizures or generalized tonic-clonic seizures as their primary seizure types. It's the smaller ones. It's the subtle staring episodes and lip smacking and chewing and gulping, or the funny feelings that come and go, or even the subtle twitches that somebody may experience. Oftentimes it gets dismissed as being something that's insignificant relative to the convulsive seizures that ultimately drive everyone's attention.
Your experience, is it usually the patient that comes to you saying, I have these weird feelings? Again, you mentioned what we call auras, funny smells, deja vu. Is it the patients that come to you, or are they brought in by a spouse, a parent, a family member who has noticed these weird behaviors? And I guess
That's
also
a
what I'm getting at is how often do you think patients themselves are unaware that these are occurring?
So it's been one of our interests in terms of looking at some of these individuals that just don't have any idea at all that they've even had a seizure. And in fact, that probably happens in about 1 in 5 people where they never know. And there's two histories to be taken when you're actually talking to somebody about their seizures that comprise their epilepsy. Talking to the individual who undergoes the seizure. What did you feel? What do you remember? What happened after the episode occurred? What did that make you feel like? Were you tired and sleepy and confused in a post-ictal state? They can tell you that. But on the other hand, if we're talking to neurologists such as yourself, they may say, well, I was there and I saw this thing. It happened in the hospital. And the first thing that the individual did was that they stopped interacting with me. They turned their head to the right or the left, and then they let out this awful cry and stiffened, and then this rhythmic jerking of their body for a minute. And after that, they were just completely wiped out and couldn't get anything out of them after that. So there's two ways to look at it, from an insider's view and then somebody that's looking as a witness from the outside.
So somebody, they come in and again, what we do, as you just said, we try to get the history. We try to ask them a lot of questions. In this day and age, are there things that the patient and their family can bring in that might be helpful? Videos, things like that. How often do you advocate use of technology to help you figure out what's going on?
Amazingly important question. And the answer to that one is always. And we've ended up doing a multi-center prospective controlled trial that was published in JAMA Neurology, looking at exactly that, harnessing personal electronic devices in the form of a smartphone. Almost everybody in the US has a smartphone, and even most people around the globe. So rather than speaking with somebody and using the vernacular that they've grown up with, that their culture is based upon, we can actually see what they see at home in their home environment. And as it turns out, that within a 2-minute epoch is probably about as sensitive with a good quality video as it is by talking to somebody for an hour and performing a history and physical exam. Now, we don't recommend replacement because there are pitfalls like there are in terms of speaking with people. But as a supplement, it's a great idea. And they're everywhere. We've seen people that have seizures on surveillance videos in stores, in restaurants. We see smartphones that are out in public, smartphones that are inside the house. They're everywhere. There's virtually no place that's unchecked with somebody that has a camera to take your video.
We when I was I think my second year in residency, I had a patient in the emergency room who came in who was at work and went into the back stock room, and all of a sudden everybody heard this rhythmic shaking of stuff, and there was a security camera, and we were able to see the video, and there it was, having a seizure. You're absolutely right. Yeah, that's always watching, I guess, but maybe this is a good use for that technology. So somebody comes into your clinic, they say, I think I might be having seizures, I'm having these spells, convulsions, whatever they're having. What are the next steps after that?
So the next step is, after you've had a chance to interview everybody and understand what you think is taking place, then there's additional testing that's performed. Neuroimaging of the brain, taking pictures of the brain in the form of an MRI, looking at details areas within the anatomy of the brain, most of the time the temporal lobes in adults, and an EEG, looking at the brain waves with wires that are pasted on the scalp for temporary period of time, and then analyzing the electrical activity to see if it conforms to somebody that has a state consistent with a person with epilepsy or something that's not. So by using all of these tools, we can then arrive at a more consolidated diagnosis of epilepsy and then move into the treatment phase. And for the treatment phase, the primary approach is to use anti-seizure medication.
To that, you had mentioned at the very beginning about the causes of seizures of epilepsy. Can you speak a little bit about when you get say, a brain MRI, what kind of things are you looking for that may actually be the cause of somebody's seizures rather than a inherent epilepsy?
Yeah, so that's a good question, and there's great variability, and a lot of that depends on the resolution of your camera. That is, everybody's familiar with looking at scenes and taking pictures of different scenes and people using something that's a cheap throwaway camera like an Instamatic, and in comparing that to somebody that has a high resolution 35 millimeter camera, the difference becomes obvious. Well, it's the same thing using neuroimaging techniques with MRI. And so what we look for in somebody that's presented with seizures is we look for both the obvious and the subtle. The obvious usually is identifiable on CT scanning or MRI in the form of a subset of people with brain tumors or evidence of previous head trauma or infection or blood vessel abnormalities, or in a certain group of people that oftentimes we see at Mayo Clinic, we may see subtle scars that are more difficult to see, that are oftentimes not revealed by CT scanning of the brain, where you have to really drill down and work with your neuroradiologist or your skilled radiologist to see if you can't find that certain needle in the haystack, because it only takes an area of dysfunction, not an area of anatomical abnormality, to trigger epilepsy. And even in people that are successfully operated, that ultimately have pathological analysis, there's maybe 20%, probably less now with our imaging capability, that have normal appearing brain tissue, despite having epilepsy that then has been remediated by surgery.
You raise a really interesting point. I kind of think about when I talk to patients is an MRI can give you a picture of the room, but it doesn't always tell you what the wires inside the walls are doing.
Right.
Right.
Yeah.
And so that's,
Yeah.
but sometimes you get maybe a strong enough picture, you can get, I suppose, x-ray vision and look at those wires.
Yeah.
Or maybe that's where the EEG comes into play. People have, neonates, people, very young babies can have seizures all the way up to the latest stages of life. Through the entire continuum of life, people can have seizures or epilepsy. Is it always for the same reason? Or do kids have seizures for different reasons than adults? And what are maybe the most common reasons for epilepsies in the different age groups?
So yeah, kids have different reasons than adults. And there's a spectrum of cause as you move throughout the life cycle. In the early stages of life, we see more problems associated with inborn errors of metabolism or congenital brain malformations. In the young adolescent, teenage years, trauma predominates. People with head injuries, car accidents are a major cause of adolescents and teenagers with epilepsy. Moving into the middle-aged group, we see new onset of seizures that are associated with brain tumors, primary tumors of the brain, such as gliomas, things that arise intrinsically without spreading throughout the body. And in the elderly, we see causes such as stroke, dementia, Alzheimer's disease as the primary feature. So quite right, your age is very important in terms of identifying the underlying cause for people with epilepsy.
So somebody's come to you, you've done your extensive workup, imaging, EEG, you start heading into the treatment phase. Can you talk a little bit about the different treatment options, um, and it may be based on whatever underlying, imaging findings you found or didn't find.
That's where the rubber meets the road, as they say, and ultimately what's really important to improving patient quality of life to ensure that they don't have any further seizures. But we start with anti-seizure medication, and it's not like an antibiotic that you take for 7 to 10 days. We're committing somebody to years when we diagnose them with epilepsy. And as I say to my patients, it's a good time to have epilepsy because we have a lot of new treatments that are a lot better tolerated, new treatments that are much safer on the body, new treatments that have different means of access, either through taking it as an oral tablet, a syrup, an intravenous formulation. So there's good news on the anti-seizure medication administration. For those that are either caused by some process that requires surgery, we look at the intrinsic nature of the cause. And if it's something bad, like a brain tumor that potentially could grow and cause more problems, then that needs to be removed. And oftentimes that satisfies the seizure control with the use of ongoing medication. But there's probably about 20 to 30% of people that have uncontrolled seizures, no matter what their exposure to any of the anti-seizure medicines, assuming the right and appropriate dose and drug and the correct diagnosis. And for those people, we have other treatments as well, new types of devices that can be implanted under the skin, on the head, that use electrical activity to fight fire with fire, if you will, where the seizure may be detected and or identified, and then an electrical pulse is delivered to that area or a distant area to decrease seizures slowly over time.
Seizure medication has come a long way, and to the point where he started touching on some of the more invasive things, stimulators, vagal nerve stimulators, responsive stimulators. How about open surgeries? Is there an option for some patients to have a surgery to remove, as you were saying, that little part of your brain that's misfiring or acting up?
Absolutely. And, at our epilepsy center, we have dedicated neurosurgeons and an entire team that are designed just for that purpose. And for the vast majority of people, perhaps approaching about 66% to 2/3 of people, if you will, they respond to medicine. And so the end result is good news. But for those that don't, then there's the option, if seizures continue and are resistant to medication, for the idea of surgery. And one of the things that also now is able to be performed is laser surgery, which back when I was doing my initial training, I never thought possible that somebody would be in the hospital for a day and walk out with no further seizures. But that's what we have here and now. And so oftentimes we take as minimalistic approach as possible if that's something that a particular patient may be amenable to. Now, if there's a larger sort of lesion, if there's something like a growth that needs removal, then the formal craniotomy with removal of the skull flap and removal of that specific lesion is then undertaken. But surgery is oftentimes both neglected and or delayed when early surgery may be potentially curative for a significant minority of patients. And I would be also probably remiss if I didn't add to that comprehensive approach when we talk about surgery. It's important to understand that there's other treatments beyond just medicine or just surgery. We use many different techniques together, including drugs, surgery, devices, and also diet. And diet plays an important part for individuals, knowing that they have a regular and well-balanced diet, or even in some knowing that they have a low glycemic or a diet low in simple sugars to try to take care of their seizures. So we have a whole spectrum of potential management issues that can be obtained through a comprehensive epilepsy center.
I think that's probably good news for a lot of people, because something that I know you've seen in your career is that seizures are really scary to people, and being in the hospital, somebody can have a stroke, a heart attack, a whatever, and, people are on top. But boy, if somebody has a seizure, I mean, it seems like even sometimes the most experienced ICU doctor can be just,
Yeah.
frozen in their tracks. And then you take that, put that in, as a parent watching your kid, it can be terrifying. And I've heard of parents getting PTSD from watching their kids have epilepsy. After that diagnosis is made, um, what is the prognosis in general of somebody who has epilepsy, and how do you counsel family members and patients about what they can expect going forward?
So to your point about it being scary, you're 100% right. And I remember an individual that was in the hospital with their caretaker who was there because the individual had seizures. The patient had a convulsive seizure in front of her, and she didn't know what was going on. She thought he was having a stroke or a heart attack, and started crying. It affected her that strongly. I'll
Wow.
never forget that when I saw that. But to your point, what about prognosis? What happens over time? Well, again, good news, I think, for people. Most of the seizures that patients experience can be controlled with medicine. And over time, most will enter a remission, similar to other types of neurologic and medical conditions that can be stabilized and then remit in terms of their disease process. So at some point in the future, when we see things that are clearly stabilized with no seizures, the duration has been a prescribed period of time, oftentimes within years. If someone's very motivated and not reliant on continuing to drive at that point of transition, then we'll often offer them a trial of tapering off of their anti-seizure medication, with the understanding that not 100% are effective, and that if there's a breakthrough or a seizure that occurs despite our best intentions, that everybody around is aware of what's happening at that point in time. But overall, I think the prognosis is good. Now, being in a center that deals with patients that have very highly uncontrolled epilepsy, most are not of that category, but out in the context of the real world, we see a great variety of epilepsies, most of which are managed and some of which remit following medicine or even independent of medicine in developing countries. We've seen that as well. So
Interesting.
quite a spectrum.
Where can people go to learn more about seizures, about epilepsy, about caring for people with epilepsy?
I think that's a great question. And while, the program may be a teaser, I hope, for individuals to get more education by contacting the Epilepsy Foundation of America at www.efa.org, or the International League Against Epilepsy. They have a similar website that people can access through their computer. There's a dearth of information that is available for them in just about any type of age, gender, disease state, epilepsy syndrome that you can imagine, and that we couldn't possibly cover in our short interview today.
Oh yeah, there's so much more. This is an area that I find fascinating. Obviously, you do as well, and I appreciate your time. Last question. So I know you're a big Buccaneer fan, and Tom Brady. I don't know if you saw the other night. I mean, within a minute, game-winning drive yet again, best of all time. How many more years does Tom Brady have in him?
So, he is the GOAT, and the GOAT is and has been proven to be ageless. So how many years? I don't know. I think, we've seen him hang up the towel once and then come back. And so I'm going to be, I guess, less clairvoyant on this one, knowing that once bitten, twice shy. So I think that remains to be seen, but he's still got it. And old is definitely in the eyes of the beholder, for sure in his case.
Very good, sir. Well, I appreciate it very much. Thanks for your time, and thanks everybody for
My
watching.
pleasure.